1 and then chapter 22. And 21, hopefully we don't have to spend as much time as we did before, because most of it's all about diagnostics, and it's very similar to the ones we did for respiratory. All right. So same thing, a little bit of the anatomy. You know, we have blood vessels, right? That within the cardiovascular system, we have larger blood vessels, and then we have smaller blood vessels. Coronary arteries are mostly the ones involved with the cardiovascular system, and they are the larger blood vessels. And you always have to think about the heart, right? And the way the heart works, or the picture of the heart. There has to be the valves, right? Between the different chambers of the heart, right? How many chambers do we have? 4. Okay. And then, all right. So, what is here? And right? Right? There are valves here, right? There's valve here for, okay. Tricuspid, pulmonic, mitral, and aortic valve, right? These are the different valves. There's another valve going to the aorta, right? Blood vessel. Okay, so with the cardiovascular disorders, we will look at problems related to these blood vessels, the arteries, the veins, the valves, right? Because if we have problem with the arteries, then it will affect perfusion. If we have problem with the efficiency of the valves, because as the blood moves between the chambers, the valve is supposed to stay closed at a certain point and should not leak blood. But what we'll find as we go along, the valves become incompetent, not as effective, and the same thing goes to the blood vessels, the veins, the arteries. So as we grow older, as things change, as we have some of these other disorders, they affect the blood vessels, and whatever happens to the blood vessels often do affect the valves too. Sometimes some of the degenerative problems that occur in our body, like autoimmune problems, degenerative like rheumatoid arthritis, or some of those things, or coronary artery disease. If it affects the arteries, the veins, it also affects the valves. They all work together, all right? So that's what we're going to see. What is cardiac output, right? As the blood is perfused through the body, it's mostly the left ventricle, right? The left ventricle that is involved when we calculate the cardiac output. So the amount of blood ejected by the left ventricle, right? Within one stroke, that's the cardiac output. So we calculate the cardiac output based on how much the left ventricle is functioning, right? So if we have problem with the left ventricle, like when we talk about congestive heart failure, then it will affect our cardiac output. And of course, how much blood is perfusing also determines how much oxygenation, how much nutrients, right? So all those things go hand in hand. So the calculation is the stroke volume, right? The stroke, how much as the heart is pumping, and the rate at which the heart is pumping. The heart rate and the stroke volume together contribute to the cardiac output, right? And the cardiac output has to do with the left ventricular function. There are hormones that are.
Professor, you're missing. You're skipping, or you're going in a different direction.
What is that?
You're missing a lot of stuff.
That's anatomy. That's anatomy. Yeah, that's anatomy. You must watch your video to refresh your mind. The Medcom series videos. about it, okay? That's anatomy, we never put it in the exam, but it's good for you to know it so you can understand what's going on, all right? There are hormones that are produced, right, and necessary for cardiovascular functioning. So one is epinephrine. So epinephrine, these hormones, they do have effect on the way the heart functions. So example, when anything that causes epinephrine to be released, if you remember, we talked about sympathetic nervous system response, the fight or flight reaction. Remember that? So whenever we have fight or flight reaction, epinephrine is released. That's the way the body compensates. And what it does is to meet up with the body's need. Meet up with, so this is something causing anxiety, stress, and when I'm scared, right? That's a fight or flight reaction. So now the heart has to work hard to meet up with that need to be able to overcome whatever the threat is, right? So the epinephrine has an effect of increasing our heart rate because now it's ready to fight, it's ready to meet up with the challenge, right? If it increases the force of contraction, the heart starts beating boom, 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 faster than normal. Now, when the heart, remember, we said the cardiac output is a function of the stroke volume and the heart rate, right? So now it will make the heart rate increase, right? Now affecting the cardiac output. So that means the body needs more. So we get a higher cardiac output because of epinephrine that is released. And then it also affects systolic blood pressure as well, right? Because it's all pressure that is built in within the cardiovascular system. So epinephrine is one of the hormones necessary for cardiovascular function. So we have another one, we have aldosterone. And aldosterone, it's necessary. Remember, within the blood, we do have electrolytes. We have sodium, potassium pump, and all, right? So it is aldosterone that helps to control the levels of sodium and potassium. So it is also necessary for cardiovascular functioning, right? Then we have another one, atrial natriuretic peptide. It helps to control sodium excretion, and they work with the kidney. These two work with the kidney to control those levels. So, and you know that sodium and potassium goes the opposite way, right? Right, so when there's more potassium within the blood vessels, so the sodium will be released. So they go in the opposite direction. But these hormones help to control the levels of sodium and potassium. Okay, all right. So ANP, that's the atrial natriuretic peptide. That's it. So we said epinephrine, aldosterone, and ANP, right? So we did talk about the blood vessels, the arteries, the veins, and the capillaries. Now, which ones carry the oxygenated blood? Carry oxygenated blood? Okay, remember there is arteries, there's veins, there is pulmonary artery, and there's pulmonary vein. All arteries carry oxygenated blood or deoxygenated blood?
Oxygenated blood.
Oxygenated blood, except pulmonary artery that carries deoxygenated blood, right? Yes, you sure? All arteries carry oxygenated blood, except pulmonary artery that carry deoxygenated. You sure?
Yeah.
All veins carry deoxygenated blood, except pulmonary vein that carries oxygenated blood. Right? Make sure we know that. I mean, it's anatomy too. So, but, all right. So, and then capillaries. Capillaries are the tinier ones, right? They're the small blood vessels, and it is through those small vessels that we can absorb nutrients, right, through our bloodstream. Okay. So this is the structure of the blood vessels. Now, look at the vein. You see the vein? It's the lumen, or the lining, it's thinner. So it doesn't do good as much work as the arteries that carry oxygenated blood, right? Do you see it? So do you also see the vein is the blue? So it carries the oxygenated blood, and the artery is the red and it carries oxygenated blood. But the lumens are thicker because it has to overcome more, right, pressure because of its content. So the arterial walls are able to overcome more pressure than the walls of the veins. So they are thinner, all right? So the blood pressure, right? As the blood is circulating or pumped through the blood vessels, pressure is exerted against the walls of the blood vessels. That's why that picture showed you the arterial walls are thicker. So they have to overcome more pressure. They're able to deal better with the pressure exerted. So when we have problems, with the coronary artery disease, the arteries are stronger to withstand, higher pressure. So normal blood pressure, 120/80, right? That's what we hope it will be. That's what we expect with the systolic. That is less than at least 120, not more. And the diastolic less than or equal to 80, right? So there's pressure that is exerted on the walls of these blood vessels as the blood diffuses, right? So there are circulation, pulmonary circulation and systemic circulation. So always think about it. Pulmonary is when the blood, all those blood from the system or from the rest of the body through the veins gets into the pulmonary, the lungs, to be oxygenated for the gas exchange to take place, right? So we already did that respiratory where we found out where some of our, some of these disorders has to do with problems with the alveolar space, right, where the actual gas exchange takes place. So pulmonary circulation, when the blood gets into the to the lungs to be diffused or to be oxygenated, and then from within there, it has to be carried from the pulmonary now. After it's been oxygenated, it will now be distributed to the rest of the body, and that is systemic circulation. All right, systemic circulation, the systems of the body. So when the blood gets taken from after it's been after the gas exchange has taken place, after it's been oxygenated within the lungs, then it is distributed to the systems of the body. Right? So that's just a simple way of saying it. Right? Pulmonary circulation is where it gets oxygenated. Systemic is being where the oxygenated blood is now distributed to the rest of the body. So whenever we talk about systemic, it's always like going to the peripherals, to lower extremities, all the systems of the body. Systemic circulation. Right? Okay, so aging and cardiovascular system. Same thing we did with the respiratory. Remember, we did the respiratory. What happens with our respiratory? We talked about, the decreased lung capacity, right? The decreased elasticity of the lungs, decreased alveoli, decreased cilia, all those things, decreased macrophages, right? So the same thing goes to the cardiovascular system. There are things that affect the cardiac system as we grow older. Right, so an example is atherosclerosis and arteriosclerosis. So you have to be able to differentiate what those two mean, right? They're not the same, right? So as you study the cardiovascular system, you have to familiarize yourself with, atherosclerosis or arteriosclerosis. All right. So remember, it says arterial. So think about arteries, right, or the blood vessels themselves, right? Something that affects the blood vessels and causes thickness, right? Remember that I showed you the veins and the arteries and how thick or how thin the lumens are, right? The walls are. So in atherosclerosis, this is the second one, arteriosclerosis, it thickens. So remember, there's pressure exerted on the walls, right, as the blood perfuses, yielding the blood pressure. When they thicken, then it's more difficult, right? Yes.
Is that radio or
Okay. So I'll tell you how to be able to differentiate it. One is arterial. The first one is atherosclerosis, right?
Yeah.
So arterial, let me tell you that. So arterial, right? Sclerosis. It is from a Greek word. They said is atheroma, but it is plaque. So this has to do with plaque buildup. Remember people who have high cholesterol, they have so much plaque buildup. Okay, so remember we have this blood vessel wall, and I showed you one is very thin and the other one is really very, right? So with the first one, which is atherosclerosis, which is plaque, atheroma, right? Athero. Okay, so we have plaque buildup on the walls of the blood vessels. Plaque buildup. Oh, here's my vessel over here. Forget it. All right. Here's my blood vessel, right? Right here. So we have plaque buildup here, right? When we're eating those food that is high in the, okay. So we're eating it. We go to McDonald's. We buy some
chicken?
fat. We actually spend our money buying it, right? And then sometimes they tell you that it was fried in pork oil. Pork fat, right? And it's tasty. Very tasty, right? We enjoy it. So we go, we buy some. We buy some this week. Next week we go and get some more. And they pile some. And they pile some. And they pile some. Do you see that?
Yes.
This is what happens. Do you see already?
Not building up.
It's getting narrower, right?
Yeah.
Compared to how it was before.
Yeah.
Now, we continue. Hopefully we are better educated and we kind of stop. When we don't, doesn't matter. So then it's narrower and narrower and narrower. Think about it. If the blood vessel is this way, right? And look at the space here. The length of time or the pressure that it will take to perfuse blood through here, don't you think it's more pressure here that is narrower?
Yes.
Do you see why we have high blood pressure? Because if we know better and we have less cholesterol buildup, then we don't have much blood pressure. Right? So the heart also have to work so hard to perfuse the blood through. Right? We do exercise, we eat, we go, hopefully we buy that and we go to the gym after eating. Right? And lose that. But that's what happens with that. So that's atherosclerosis, the first one.
That's
Plaque buildup. You get that?
Or narrowing of the blood vessels.
And it causes narrowing. Right. Plaque buildup, right? So then the other one now is arteriosclerosis. You see, it starts with ART. Okay, arteriosclerosis. Okay, so that's the thickening. That's the thickening. So you will see that lining here, and it gets harder, thicker and harder. So the same thing, the pressure or the force of blood flow or perfusion through the blood vessels will need to be higher too, because it's too thick. it's supposed to have some elasticity to it. But with the thickness, it loses that elasticity.
What, with what thickness?
Thickness of the walls of the artery.
This is the wall.
Thickening, hardening.
What causes
It thickens or hardens and not as flexible. So that's coronary artery disease.
What's the cause?
Coronary artery disease.
The cause of the thickness.
Yes.
What's the cause?
Well, over time,
Okay, aging.
aging, over time, they become harder. And with so much pressure over time, it affects it. You know, it hardens. It hardens. So the elasticity is no longer there. The flexibility is lost. All right. So then that person will also have problem, right? So aging and the cardiovascular problem. That's what happens. All right.
So, Professor, is that, I'm a little confused, but is that the one where the plaque and the blood vessels and all that, they start like making a ball? Is that the one where they start clumping together?
No, they are clumped together here. This thing you can hardly move it. This is what happens when people have chest pain. Do you remember people with chest pain? When we will do that. So people who have chest pain, they have very narrowed arteries.
So what's happening over here? That's what I'm
Over here.
Yeah.
Over here. It gets harder and harder and thick. It gets harder and thick.
Well, what's caused, like, what is it, plaque, what is it causing the hardness?
As we grow older,
Aging.
the person may have, the person who has high blood pressure, hypertension, it's so much pressure
Okay.
sustained and maintained within this vessel. So it's too much pressure,
Okay.
and it has to be controlled. And after it beats, it's like it gets beaten up. It gets beaten up by the pressure, increased pressure, by
Like swollen,
huh?
like swollen.
Swelling,
Yeah, it's like the walls are swollen.
thick. Don't use swelling. Use thickness.
Thickening and hardening.
It gets thicker and less flexible. Because if it's hard, so as the blood is perfusing through it, it's hard to move through. But when this has not set in, the walls are flexible. So it's almost like it can expand a little and will allow that blood to move through without too much pressure. But it's almost like passing through a solid thing that cannot expand. So it's forcing itself. Over time, it's not as thin anymore or not as flexible or elastic anymore. It gets harder. And then it's more pressure that is required to be able to perfuse through it. Yes.
I had a question in regards to the apero, the first one with the
Atheroma.
plaque.
Okay.
The plaque can be removed to ease the pressure, right? Whereas with this
Say it
other one,
again. The
the
plaque.
plaque, excuse me, can be removed to, they can do something to remove the plaque so that the blood flow could,
Okay, so that's what happens. Remember, we're doing cardiovascular disorders, right? So a normal person who doesn't have high cholesterol, it's okay. They don't have this problem, right? So, but when people have cardiovascular disorders, a lot of times contributed by coronary artery, of course, the large blood vessels. The problem comes when the coronary arteries are involved, because they're the large vessels that actually are directly connected to the heart and allows for blood to get back to the heart and leave the heart, right, and be distributed, right? So, yes, you see, remember the thing about cholesterol. Remember, it's the bad fat that is not soft. So they line up on these walls and form a layer that as the blood perfuses, it doesn't move it, it's there, it stays in one spot. Then it gets narrower and narrower and narrower until there's almost no space. Now, this is what happens. this person is the person whose heart will have to work a lot harder, right? To move. And they are the ones that will have the chest pain from time to time. Because the amount of blood moving through here, the cardiac output is low. Remember the amount of blood injected from the left ventricle in one stroke. So it's not enough. It's not carrying enough. You see how much blood that will pass through here within one stroke of a heartbeat? It's little. So it doesn't carry enough oxygen and nutrients. This person will suffer from shortness of breath because they don't have enough. Yes.
Can be caused by smoking?
Oh yes. We're gonna talk about the factors that contribute to it. Yes. There are contributing factors. Some are genetic, right? Some are smoking, diet, right? Lack of exercise, sedentary lifestyle, those things.
Shortness of breath can be with both arterial and arterial.
Both. Yes, both. Now, because even if the lumen here is a little better than this, but there's a little bit more pressure built up. So that pressure means the heart is going to work harder to meet up with that demand. So is it going to carry adequate oxygenation, right? So they both have problems. But this is worse than anything because it's so narrowed, right? It's so narrowed. And it is the inner lining of the blood vessel, not the outer lining. So that inner lining that we saw gets harder and thicker and not as flexible.
In both cases, the plaque too is in the inner lining.
And this person that has arteriosclerosis can also, remember it's the same blood vessel. It's not that, we have a different blood vessel, right? So they can suffer from both. So can you imagine if the person has so much plaque buildup in addition to a hardening of the wall? So that's more complications, right? So it's even worse, right? So it's mostly the coronary arteries that we worry about. And because that's how they now come tell you, I go up the stairs, I'm so short of breath. Because for you to go up the stairs, there's a certain amount of energy needed, right? And then the heart has to meet up with that energy need. And this person, blood vessels are messed up, narrowed, and then not giving them enough oxygenation. So they suffer, they complain of chest pain. Chest pain is lack of oxygen, lack of adequate oxygenation, shortness of breath, not enough oxygen, not enough gas exchange, right? So the blood pressure increases because of these problems, right? Blood pressure, so as we're older, we tend to have high blood pressure. And because we already have, over time, these things, arteriosclerosis, they start from the time we're born. And we start feeding our kids, right? The high fat. And it starts from the time we're young. And can you imagine a 70-year-old or 80-year-old? This is a lifetime of built up of this. If they're not aware or they're not educated about, avoiding all those high cholesterol food, right? So it builds up over time. The valves, remember I was telling you, you see when we have atherosclerosis on the veins and the arteries, they happen to the valves too. So we have plaque built up on the valves too. So the valves are supposed to stay closed. So when we have plaque on the layers of the valve, when it's supposed to stay closed, the plaque can affect it and it won't close well. It won't stay closed like that. So then you will have a little bit of leakage when it's supposed to close. So there's extra volume, continuous leakage. So it doesn't allow room enough to just stop when it is supposed to close short. And then it's leaking. So that leakage affects cardiac output. It affects the efficiency of the heart. It affects the efficiency of whatever chamber that has to deal with that extra leakage. Because then if it is supposed to have, let's say, 600 volume and there's atherosclerosis on the valve leaflets, then it's now holding like 650 instead, right? Because of the leakage. And so when we listen auscultation, that extra leakage will be sounding like it's a murmur. That's an extra beat, extra sound, right? When it's supposed to close and you don't hear anything, but it's slightly open. So it's causing problems. All right, so the valves are not as competent as we grow older because of degenerative changes that occur, or any of these coronary problems. The muscles of the heart, same thing we talked about, the muscles of respiration, they also affect the muscles of the cardiovascular system. The heart muscle is really what pumps.
I just want to get clear. The arteriosclerosis.
This one?
No,
This one?
Yeah, the artery one. That one is as a result of aging
Aging.
that go along with it. And the first one starts off with diet.
Okay, yes.
Okay.
Yeah, but it's also, remember I said it starts when we are young and builds up over time. So it's also because we're older now. An 80-year-old may have more problem with this than a 40-year-old. Yeah. Okay. So we say the heart muscles, remember the myocardium of the heart is what really does the pumping, right? The heart muscle. So the muscle wall here is the myocardium. So that's really what does the pumping. But then as we grow older, the muscles are weaker. So the same thing goes to the muscle of the heart. It gets weaker too, right? So you see more problems with the older people, and they have more chest pain, they have more MI, heart attack, because the muscle is no longer there, and they have all these other problems. They have COPD, they have congestive heart failure, they have hardening, right? Atherosclerosis. All those things contribute to their problems. That's why we see more older people every time they're in the hospital, right? Dysrhythmias are common. Dysrhythmias are those abnormal electrical activities within the heart, right? So anytime we have the extra fluid to deal with, when we have congestion in the cardiovascular system, we're not able to perfuse well because of the narrowing. So there is a room for blood to stagnate, stasis. They have a lot of problems. They can suffer from blood clots because of that narrowing, and we're not having adequate cardiac output. So the amount of blood we're supposed to eject through the ventricle, right, it's small. So that means the chamber is holding more blood than normal, right? So if we're supposed to have 600 pass through here and 600 goes through, so the chamber has eliminated what it needs to eliminate. But when we have that narrowing and it's affecting, so we don't have 600 and maybe we have only 400 ejected. So we have 200 left for the chamber to deal with. So now that extra can cause stasis, stagnation of blood. Anytime these things complicate issues, because then it's allowing room, that time that it's going to take for that extra volume to sit before the next round of circulation, right? It can cause blood clots. You can have clots. So those is, dysrhythmias, abnormal electrical activities within the heart. So there's more and more problems related to aging and cardiovascular function.
So that blood clot depends on the cardiac output? Did you say that?
Yes. If we don't have adequate cardiac output and we have extra volume for the chambers to deal with, anytime we have more volume, or even congestive heart failure, they're congested, they have so much fluid, they're not able to perfuse well, they're holding more than normal, so it allows for stagnation or stasis, sitting, right, of the blood. And anything that causes or gives opportunity for stasis, blood clump together, that's aggregation, of course. So then they form clots. And that's why people who get aspirin, antiplatelet, decrease aggregation. So these cardiovascular patients right? They have to be on daily aspirin to prevent this from happening because they're already dealing with problems, right? It's there. But then they give them aspirin to prevent the clotting from taking place. So they need the daily dose of aspirin. Right? So cardiovascular disease is the number one killer, right? So what are the things to help prevent cardiovascular disease, right? So any of these things we said, it happens over time from the time we're young and then as we grow older, it's more and more, right? So but if we're better educated, we now try to adopt those lifestyles that can help us decrease. Now remember, we're going to talk about some of the factors that we have control over that can put us at risk for cardiovascular problems, right? So if we know better, we start early to decrease the length of time it takes us to start developing these problems, right? If we have a genetic predisposition, we don't have a control over it, right? Because our parents had it and we're likely to have it. But if we're better educated, if maybe by the time we're 60, we may not develop it yet. It may wait until we're 80, right? But if we don't do what we need to do, we may develop it at 50, knowing that we have no control over that genetic predisposition, right? Okay, so we need to, smoking cessation, right? Smoking is a major contributor to cardiovascular problems, smoking. And then dietary fat reduction, right? We need to decrease fat reduction, right? Fat in our diet and, be more educated about our choices of food and the preparation of food, when we prepare food, right? 2 servings of fish, so they're suggesting at least, remember, a lot of the high cholesterol is because of animal fats from the meat that we consume, right? The red meat. So they're suggesting incorporate fish in our diet and not meat or every day, and not red meat every day, right? So that's why it's saying there at least 2 servings of fish weekly, so that even if you can afford fish 5 days a week, at least 2, so that you don't eat red meat the whole week long. That's what that is. Incorporate healthier diet. Exercise, incorporate exercise in our diet, in our activities, right? Exercising, avoid sedentary lifestyle, right? So these are some of the healthy lifestyle we need to incorporate in our lives. Now, American Heart Association, right? They have this Go Red for women, and they want to encourage. They do this, wear red on a certain day. I think it's February because I heard it on the news. Right? When?
Friday.
This Friday, right? This week?
Friday.
Last Friday, yes, it was last Friday. Go Red for women. So they encourage people to wear red, just because they said that a lot of women die of cardiovascular problems than men. And the reason is because women have these problems, and the way their symptoms are not typical symptoms. They're not the typical, I have chest pain. They're not typical. There are other things that one would think, I wonder why this is happening, right? Like a little bit of back pain. So women's way of experiencing these symptoms are different. So it takes them longer to go and seek help. So women suffer more from the effects of cardiovascular disease than men because they don't have the typical symptoms, so they take longer. So they said, I'll wait till the end of the week. Let me go to work and come back. Meanwhile, they are having less oxygenation, and whenever we have inadequate oxygenation, we're having areas of the muscle die because of poor oxygenation. So women suffer more from it. So they want women to understand that, we need to bring that into light, everything we're doing, and be more conscious of that, right? So color red and red dress linked to the ability to understand that women have issues with the cardiovascular problems, right? So how do we assess? Assessment, same thing, right? When we're gonna do assessment, we wanna know about the history first, right? So we do interview, we ask the patient, tell me, what's the history, why are you here? Right, what's the reason that you came? We wanna ask family history, right? So what else do you wanna ask? What are the symptoms you're exhibiting? When did it start? Is there something that aggravates it? Is there something that makes it better, right? History. Medications. What medications are they on, right? We talked about the aspirin. Are they on aspirin? Daily aspirin or not, right? Something like that. Are they hypertensive? They have all these other problems, right? Are they diabetic? Remember we talked about diabetes and effects it has on the blood vessels. So can you imagine somebody who's diabetic and hypertensive? Coronary artery problems, right? So it's even more complications. And that's why they suffer a lot of complications, when there's all these comorbidities, right? So we get all that information, what medication they have, what if they've had any surgery in the past, if they've had what are their different problems, how many meds they are on, and the meds will tell us some of the other problems, right, that they have. Do they have autoimmune problems? Do they have degenerative issues, right? So what are the problems they have? So we want to get that information and gather that data, right? So physical assessment, we do physical assessment on the patient, right? Cardiovascular. Remember, each time we do any of these sections, any of these systems, you focus on the system, right? So we're now going to focus on the cardiovascular system assessment, right? So what are some of the things we need to assess for, when we are focusing on the cardiovascular system? What are the
Cardiac output.
the cardiac output? What's the cardiac output? What else? Perfusion by okay, physical assessment. What do we vital signs? Blood pressure. What's their blood pressure?
Any allergies?
Any allergies? What are their labs? Right? Huh? Any history? Physical assessment. Physical assessment. Right? Respiration. What's the oxygenation status? Pulse ox. Temperature. Okay. Pulse ox. Right? Remember capillary refill. Color. Right? Okay. Edema. Right? What's their perfusion status, right? The pulses, remember the pulses all over the body, right? Yeah, remember you checking it, you check the heart rate, you check, is it bounding, is it faint, right? Yeah. Yes, is it steady? Any chest pain, right? Okay, any pain, are they experiencing any pain? Diagnostics, we look at diagnostic studies. What are the, diagnostic studies, lab work? What are the lab work focusing on the cardiovascular system? What are some of the labs?
Cholesterol.
Cholesterol level. Huh? Okay, yes. EKG, yes.
BUN and the creatinine.
BU and creatinine, kidney function. Stress test. A lot, right? Labs, HMP. Hemoglobin hematocrit. We want to know how much blood volume they have. Do they have enough hemoglobin? PT, right? We want to know what's their bleeding factor, right?
We also do complete blood counts.
Yeah, complete blood count, CBC, right? CBC, right? We want to know those things, different things, right? Those hormones we talked about. Remember there's epinephrine, aldosterone, ANP, right? Okay, so a lot of diagnostics. So, of course, health history, that's what we talked about, any family history, any health promotion, what are their lifestyle, what kind of lifestyle they have, right? Are they involved in any health promotion activities, right? Are they incorporating exercises? Are they eating healthier food, right? Making healthier choices of food, right? Medication, are they adhering to their medication, complying to the, the medication regimen, right? Compliance. Physical assessment, of course, these things, it's in your paper already, right? Oxygenation, you do inspection, same thing. When you are getting your history, you're looking over the patient too. You're assessing them, you're looking at their color, because it has a lot to do with their color and oxygenation, right? The skin color, the extremities, the hair distribution, because perfusion carries nutrients. The blood carries nutrients. So as it is perfused through the body, when you're looking at the person's hair, the hair distribution, it also tells you about their nutritional status. People who are malnourished, you can see it in their hair distribution. When you can see that they're not well taken care of, or they don't look very healthy. You can see that. Nails, brittle nails, nails that are really, cutting all the time, rough nails, skin, edema, color, all those things. Looking at the extremities, jugular vein distension. Remember, we did talk about that for congestive heart failure. Patients who have right heart failure, they have jugular vein distension, right? So because of that backup of fluid, so much fluid, right? They have congestion in their pulmonary system. Capillary refill, sluggish, right? Is it brisk? Is it sluggish, right? Is it, right? Clubbing, same thing as the COPD patient, right? We talked about patients with the respiratory problems. It goes hand in hand with perfusion, with cardiovascular, right? If they have problem with perfusion, not adequate blood, not adequate, right? Atherosclerosis, it's going to affect oxygenation. So that can also be seen. So that patient with COPD will have clubbing, and the patient with congestive heart failure will also experience clubbing of the fingers, because it's prolonged deprivation of oxygenation. Okay. So that's clubbing. Physical assessment, right? We did talk about this, do inspection, then palpation, right? Palpate for apical pulse, right? Point of maximal impulse. Okay. Now you have to know the landmark where you can identify the apical pulse, because if you want to palpate for maximal impulse, you want to palpate. You want to know the right landmark for it, right? What is the landmark? Right? It's something you have to know until you graduate. The fifth intercostal, fourth and fifth, between the fourth and fifth intercostal space, mid-clavicular line. And it is interesting. So sometimes people forget where is the mid-clavicular line? Where is it? Where is the mid-clavicular line? Interesting. It is interesting. So you have to remember that. So you know you have your clavicle here, right? And then you have it on this side too, right? So but it's on the side of the heart, the left side, right? So midway between the clavicle is mid-clavicular line. And you trace it all the way down. Because sometimes people think this is the mid-clavicular line. No, this is the sternum, right? So it is midway within this short clavicle here, and you go down between the fourth and fifth. And usually for women, it's usually underneath the breast. For men, it's easy, right? So always think about that. So being able to palpate the point of maximal impulse and assess that. Temperature of the extremities, poikilothermy, being able to assume the temperature of the surrounding. Is it warmer than normal? Is it warm, right? Is it too cold or stuff like that? Because remember, with circulation, we need adequate perfusion. That it should be warm, right? Whenever we have cold temperatures, they're having problem with good circulation, right? Edema, we assess for edema, right? And you assess by pressing indentation, right? and how long it takes for that skin to come up, right? The indentation to come back up. Is it 1 second, 2 seconds, 3 seconds, right? 3 plus edema. That's why you say 3 plus edema, 4 plus edema. So it's like takes so long, right, to come back up. Home and sign, assessing, doing that dorsiflexion to know if they feel any pain on their calf, right? Remember we're saying if we're having extra fluid because of atherosclerosis, then we have stasis, and that's opportunity. And then it is complicated by immobility, right? People who are immobilized, they're laying in one spot. So now they have congestive heart failure, they have edema, just less perfusion, less blood return to the heart. So it's an opportunity. They're laying in one spot. That's why we need to turn them. Otherwise, the stasis can take effect and they have blood clots, right? So when we do home and sign, we want to check for, possibility of blood clots, and they experience that as pain on their calf, right? And that's the edema of the extremity. And when we check for home and sign, we do dorsiflexion. We have them, right? See the direction of the foot, how we have them. And when they do that, you're putting stress on that muscle on the calf, and they may feel pain if they have blood clot there. All right, so physical assessment, we do auscultation. Auscultate for heart sounds, right? For the lungs, we did lung sounds, right? And we thought, we know about those adventitious lung sounds. Now here is the heart sounds. The heart sounds, and it is S1, S2, and adventitious sounds are the extra beats, which are the S3 and S4. And the murmur is part of the S3 beats or S4. And when somebody has murmur, we need to identify. Sometimes people have it from birth, and maybe it's not bad enough and it's not having any effect. And they're not being short of breath, they're not having any symptoms related to the murmur. So they don't do anything. With cardiovascular system, when they have these problems, they have murmur and they don't have any symptoms, they don't do anything. But it's when they're becoming symptomatic, they are complaining of, very shortness of breath, poor cardiac output and all those things. Then they may now decide to do something about it. Okay? So S1, S2 are the normal heart sounds, right? And then S3, S4 are the gallop beats, extra beats, right? Abnormal beats. That should not be. So we don't want to hear the S3, S4. We don't want to hear those extra beats. We want to hear the normal lap dab, right? Okay, murmurs, right? We talked about that. Then pericardial friction rub. We talked about that too with the respiratory, right? Because there's the lungs and it's the pericardium. Now we can actually hear it also with auscultation. Friction, the grating sound, remember? The grating sound that is heard because of the layers of the pericardium being inflamed and rubbing against each other. When we take a deep breath with perfusion, then you hear the pericardial friction rub. Okay? So, same thing, this was in the respiratory one we did. Diagnostic studies, Joint Commission, and National Patient Safety Goal, making sure we're doing the right thing, keeping patients safe, right? Improve accuracy of patient identification, because they had to do this because there used to be a lot of mistakes being done, right? When a lot of us healthcare providers, we make mistakes in identifying patients, right? So Joint Commission now mandated healthcare facilities, healthcare workers, make sure we are identifying our patients correctly, right? Improve accuracy. 2 patient identifiers, must use those 2 patient identifiers all the time. 1 is not enough, right? So make sure we're asking the patient. If the patient's alert and can talk to you, you ask, what is your name? What's your date of birth, right? If the person can't talk to you, that's different. So you can look at the patient's paper and look at the name band, right? And make sure it's the right thing you have. When you're giving meds, you're gonna have the 2, and you check that. Make sure you have two identifiers for med administration, for blood, for samples, right? Collecting samples, and also for blood products, administration, blood transfusion, right? So you stood patient identifiers and label your containers or samples right in front of the patient. Don't walk out of the room with the urine sample or the blood sample, right? Label in front of the patient because it helps to prevent mistakes. Diagnostic studies more immediately prior to any invasive procedures. You know, when they used to cut out the wrong breast, the wrong leg, the wrong arm, the wrong eye. So they need to stop, have that time, they call it time out, during for any procedure to be done. All the people involved for the procedure, the surgeon, the nurses, the anesthesiologist, you know, whoever is within the crew, they need to have the timeout where they stop and they want to identify and make sure that they have the right patient, they have the right, that you know, the procedure is for the right side of the body, right? So they do that, and the documentation corresponds to the patient that they have. But you know, since the time they started it, people still did mistakes, you know, which is unfortunate. But so just to confirm that you have the right patient, the right procedure, the right sites, and availability of appropriate documents. All right. So the other thing about the Joint Commission National Patient Safety Goal, when you get a telephone order from the doctor, when you get a lab report from the lab, you want to make sure you read back and say, I want to read back what you said to me. And you confirm that by reading back to them, and hopefully there's somebody else who's listening at the same time, and they confirm with you that that's exactly what the doctor said, and that's exactly the lab result the person called you, and you get that lab result and take it to the appropriate person to address it. So you don't wait until the end of your shift to address an abnormal lab, right? Okay, so that's the National Patient Safety Goal. So there are non-invasive studies. So these we did with the respiratory, the chest X-ray, right? The CAT scan, the MRI is all the same. Now tell me about the CAT scan. We spent a lot of time talking about CAT scan last time. And I told you several things that you must know from now till the time you graduate. Your patient is going for CAT scan. Okay? Tell me what are some of the precautions? I know everybody did sign. Okay. It's very clear. Okay, tell me one thing you can do for your patient going to.
You got to sign the consent form.
Consent form, okay. All right, Bianca. Okay, Bianca, what's one of the stuff you need to do for your patient? Remember I told you several things about CAT scan.
I guess like checking tattoos and jewelry.
What is it?
Tattoos and jewelry.
Tattoos and jewelry? No, for CAT scan. CAT scan. What is done with CAT scan?
You have to drink.
Okay.
You have to take a.
Okay, wait.
You have to make the person allergic.
Allergy, right? Allergy. Allergy is so important for CAT scan, right? It's one of the most important things. Allergy, right? Check for allergy to die, right? And Wendy? Okay, Wendy, what would you ask in terms of the allergy?
If the patient has any shellfish allergy, iodine allergy.
That's right. You remember that? You can ask if they have allergy to contrast eye. Some people don't understand what that means. So you can simplify it by saying you have allergy to shellfish, you have allergy to iodine, right? Okay, so that's good. Gabriel, what else? Miss Gabriel, what else about CAT scan? What else do you need to ask? What else? What are the things? Do you remember all the different things about CAT scan? All right, so.
Vital vitals.
Oh, of course. Oh, what's the most important thing? Remember the lab work. Remember the lab work I told you? What is it about the lab work?
the kidney has to be able to.
Kidney function. Remember, the dye has to be eliminated through the kidney, and we want to make sure the kidney is working well. If there is a problem with the kidney, what is going to be done? Nasim? Nasim?
Yes. No.
Oh, no, wait, Nasim, you said a lot. Malgazada. Malgazada?
I'm sorry?
Yes. Malgazada.
Yeah, I am.
Yes.
I'm sorry.
If the kidney function is not good, what's going to happen?
They're not gonna do the test.
You have to inform your physician.
They're not gonna do the test until it comes like to normal.
Thank you. They give you something that has to be rescheduled.
Okay. It will be rescheduled, right? And then they do what?
They give you some injection or something for you.
Leslie? Do you remember what will be done? Remember I told you something that they will receive?
Something to build up the.
Yes. What is
I
that
can't
called?
remember what, I can't remember.
Anybody remembers what they would take to build up the kidney function? Mucomist, yes. Mucomist, remember that? Yes, that's CAT scan, same thing. Whether it's for cardiac or respiratory, CAT scan is the same, right? MRI. What do we need to do for MRI? Remember?
No metals.
No metals, yes.
Same thing.
Metals in terms of
Pacemaker.
pacemaker,
Earrings.
earring. What else about metals?
Anything with metal. The joints.
Implants.
If the patient has the, we call that thing,
Pacemaker.
pacemaker.
Yeah, we talk about pacemaker, right? Pacemaker, jewelry, implants, right?
Yeah, I have to ask one. I'll ask the patient, see if the patient is claustrophobic.
Yes, and then what do we do?
And I advise,
They send off and
You have to have an open one.
Medication.
Okay, so they may have the open one, but you know what? Not every place has the open one. Some places don't have the open one, so then what we're gonna do?
Talk to the doctor.
Sedate them. They may be sedated. They may get some medication to calm them down. Yes, that's it. I don't know how they.
But they
They
don't.
got
First, suppose they don't want to be sedated.
They don't sedate you all the way.
Oh, it depends on what's going on with them. Are they really, so sick that it must be done? Can it wait? I heard that the open one has a long list of people waiting for it. So that's like months, months. Good. Same thing for respiratory, same thing for cardiac. You gotta know, these diagnostics are very similar, okay? Electrocardiogram, same thing, they do. And that's the electrocardiogram is electrical activity of the heart. And they say 12 lead, that means it's looking at the heart from 12 angles, 12 different views of the heart. So 12 lead EKG, okay? So, and of course it shows, remember we said with the cardiovascular system, they are prone to dysrhythmias, right? Abnormal electrical activity. So electrocardiogram will show the electrical activity and it will tell us when it is abnormal or when it is normal, right?
Yeah.
And then another one is the ambulatory electrocardiogram, which is the Holter monitoring. So this is cardiac now. Remember, we're focusing on the heart. So sometimes the electrocardiogram will give us a snapshot of what's going on, right? But the Holter monitoring, people like, sometimes people will pass out, right? They pass out, they don't know what happened, they come back, they go to the doctor, they check everything is fine. They don't know what's the problem, right? So they may decide to put on the Holter monitor. Holter monitor is one for 24 hours. And they go about their daily activity except they can't take a shower, right? And it will record the electrical activity for that individual for 24 hours. So it will be able to pick up if there's occasional abnormal electrical activities.
Is that a machine that they put on?
It's a little box that they, it's a little box that they wear. If you've been in the hospital, they have telemetry boxes that in patients who are in telemetry, right? So they put these electrodes and they wear the box in the hospital. But when for Holter monitoring it's similar, and they can go home with it and come back the next day. They just can't take a shower. They will have to leave it on. They can't remove it. And sometimes, the way it is, they give them instruction. Sometimes if they feel something different, they can press something on that box. So it records that particular moment, whatever they felt. But then they come back 24 hours later, they have it removed. They will take the box and analyze the limits, okay? Echocardiogram, right? This is cardiovascular now. Echocardiogram. Ultrasound of the heart, right? It visualizes the vessels, those chambers of the heart, the vessels of the heart, the coronary vessels, and it shows the movement, how the blood is perfusing. And it will show, the structure, right? The size, the shape, the position, the valves. It will show. If there are those leakage, it will show those extra bits, extra leakage of blood. The echo will show, right? The heart structures, the valves, it will show everything. All right, so there's no prep for echo. They just come and they lie down. They use the gel, right? And they visualize it on the screen. Okay, and take pictures. And the cardiologist will look at it and read it and determine, it helps also to show about the chambers of the heart, right? Or that left ventricular ejection fraction. Remember how much blood is ejected within a stroke of a heartbeat. The cardiac output, it will show how much. So that's, people, cardiovascular problems, they look at the echocardiogram. And that helps to inform them about decisions to take. Yes, transesophageal echocardiogram. Transesophageal. So it goes through the esophagus, right? And they start a probe to look at the heart from that angle. The TEE, it's called TEE. And the patient is going for TEE, transesophageal echocardiogram. It gives a clearer picture than the echocardiogram. Remember the echocardiogram, they put a gel on the skin and they look there, right? But if they don't see what they're looking for, they may decide to send the person for TEE, because TEE gives a better picture, a clearer picture, looking at the heart from the top. All right, like going through here and then it will visualize. So they do that. Now, remember when we talked about bronchoscopy?
Yes.
Do you remember what you have to do for your patient? So, a patient who has gone through bronchoscopy, what's going on?
Don't give them anything until they get
That gag reflex. Same thing goes for this person for TEE. Right? Because you're inserting a probe there. When they come back, you want to make sure they have gag reflex before you can feed them. Now, remember, same thing that they do for that person going for bronchoscopy. Same thing, they're going to numb the area too, right? MPO, because we don't want them to gag and aspirate contents. So they're going to be MPO. Is it like 6 to 8 hours prior to the procedure, right? Okay, so, vital signs, monitoring, right? All right, so make sure the patient understands that. And of course, consent. They have to sign consent for both of them, right? Yes. Okay. Stress test. Now, well, you have to know all these different tests, right? For cardiac, they are sequential, right? So when somebody comes with a cardiovascular problem, like chest pain, right? Chest pain, dizziness, fainting spell, TIA, things like that. They do it in sequence. So they come in, we do vital signs, they draw blood, then they do an EKG, right? Electrocardiogram while they're there. Then they want to send them for maybe chest x-rays, then echocardiogram. Then after they've done the echocardiogram, they're looking at the echo result. Maybe they don't see the problem, right? Then they said, okay, they may do TEE or maybe not. They may want to go to the next step, which is stress test. So it's sequential, right? So once they do the echo, they do all these tests, and then they go to the next step. So after each one, it will determine the next step, the next thing they want to do, in order to figure out what the problem is, the root of the problem, right? So stress test. Stress test, different things they do, right? Stress tests can be exercise stress tests, only for those people who can exercise, right? There are people who are bedridden, they can't exercise, right? They can still do stress tests on them, but they use medication, right? They do use medication. Stress test is about stressing the heart. Remember, we're talking about how much perfusion, how much cardiac output, how much blood will be able to pass through that blood vessel, right? So then in this time, they want to stress the heart and monitor the patient. So that's what the exercise stress test does. They go put them on a treadmill, right? Treadmill has a speed, right? So they start with a certain speed and then gradually increase the speed. So they know a measured amount of speed, how much they are inducing the heart or stressing the heart to make it work harder. So when the heart is stressed, whatever it is, the body compensates by having the heart beat faster. The heart rate goes higher, right? Maybe epinephrine released, because it's almost like fight or flight reaction going on now. Because now I'm working, doing this exercise in order to meet up with the need. So then it is done with a cardiologist. Next to a cardiologist, he's the one that monitors. This is not the one the nurses or anybody else would do. The cardiologist will be there for the stress test. The person has electrodes attached, right? Yeah. So they monitor the patient, monitor the electrical activities that will be generated because of the stress-induced exercise, right? So that's the person who's going through stress test, and they have all these, right, electrodes attached, and they getting the strips, and it will show the electrical activities. The cardiologist is right there. Now, as the heart is induced or stressed, it has to meet up, right? Somebody who has problem, like, coronary artery disease, narrowed blood vessel, arteriosclerosis, right? Their heart is going to really suffer this. And they will now, during this stress test, as the speed is increased, they may complain of chest pain, shortness of breath, chest pain, dizziness. They can even try to throw up. So that's why it is a cardiologist that stays next to the person and not just a nurse, because he decides what to do. He looks at the the strips to see what are the rhythms, right? Before and decide to stop or not. Make sure the patient is fine, all right? So that's what happens with stress tests. They have to be, there's a prep to stress tests, right? They have to be MBO, make sure you familiarize yourself with what to do for your patient. It's on your, there's a big page on your book with all the diagnostics. What to do for the patient going for stress tests. They're going to be MPO, right? 8 hours prior to, right? They won't eat anything, because as they are stressed, they may throw up and get sick. Is it MPO though? 4 hours.
I think it's
4 hours.
Yeah, it's 4 hours.
4 hours, and you have
2 to 4 hours.
Does it say 2 to 4 hours for stress test?
Before test.
Okay, 2 to 4 hours. Yeah, okay. And of course, now, another thing, remember, they have, a lot of them have high blood pressure, have, problems. So they have certain medications. There are certain medications that they will tell them to hold off, because those medications can affect the heart functioning. So they want to induce them first and do this, and then they can take their meds first. As long as their blood pressure is good, under good control. If it's not good, then they will decide what to do, to give them medication, whatever they want to do, all right? All right, so that's cardiac stress test, exercise stress test, right? So the other ones I said, they use the medications, like thallium stress test, where they use medication. Some of the can I say, arrhythmic medications to stress the heart. So they inject some of those medications, and it would not cause the heart to, still be stressed and work harder then.
Can you give us an example of one medication that you would stop if you were to do a stress test? If the patient has high blood pressure, then they would take their high blood pressure medication, right?
Yeah.
But what would you stop? Like what kind of medication?
Can be held, right? Prior to
Yeah.
going for the stress test, right? They would usually they would tell the person, if the person is taking aspirin, you can take your aspirin, take your blood thinner. I mean,
Warfarin, you can take all those.
it's mostly the ones that affect the functioning of the heart, right? Antiarrhythmic meds, maybe. Yeah. Like metoprolol, I'm thinking metoprolol, but I have to be sure of that, yeah. Some of the, I'm thinking propranolol, something like propranolol, that's beta blocker again, like the laws. But there are some medications, but I will check that for you. Some medications may have to be held and then they go and then they can take their medication. But the most important thing, their blood pressure has to be under good control. So if it's like 180 or 200, they're not going to start stressing them without giving them medication. So other tests, they have tiltable tests. Sometimes people have dizziness, they get up, they get dizzy. They don't know what's going on, right? So they may now decide to do orthostatic. It's called orthostatic blood pressure, right? Orthostatic blood pressure. Orthostatic blood pressure when they're laying down, standing up, and sitting down. And they use it to compare. Okay. So till table, they can strike them onto a table and then put them in different positions and monitor their blood pressure and see what's the difference. Then we have Doppler ultrasound. Of course, we're checking for blood clots, right? Impaired blood flow because of the blood clots. Those people who are immobile or complain of the positive Homan sign, when we check it and they feel pain on their calf, they may now do Doppler to know if they had a blood clot.
You didn't do arterial stiffness index, did you?
Huh?
The arterial stiffness index?
No.
So we're not going over there.
No. Yeah, that's with peripheral arterial diseases. With the peripheral arterial diseases, It's, you can know it, but it's fine. Then I said Doppler ultrasound, same thing, they use the gel also to check for blood flow. Okay. And then we have radioisotope imaging. Radioisotopes, they use radioisotopes IV, intravenous, and they monitor it as it perfuses through the blood, right? They give it by IV, intravenously, and it flows with the blood, and they watch on the monitor, how it flows, and it will show those areas of occlusion, narrowing, all those areas. It will be showing on the camera as they visualize. It detects any areas of ischemia, right, damage, or poor perfusion. It will show them. Thallium imaging can be done. Mucus scan, these are using some radioisotopes to monitor, to visualize the vessels, to see areas of ischemia, damage, or poor perfusion. And then we have the PET scan, PET scan, positron emission tomography, that can also show better picture, clearer pictures. Blood studies, cardiovascular wise, lipid levels, right? We want to know what the triglycerides, the cholesterol level, phospholipids, C-reactive protein, homocysteine levels. Some of these things are high in the presence of cardiovascular disease. Their levels are elevated when somebody has muscle damage, cardiovascular muscle damage. Cardiac biomarkers, these are typical. You have to know about the cardiac biomarkers from now till you graduate, when people come in, they have chest pain because of cardiovascular disease, coronary artery disease, atherosclerosis, chest pain, angina. They come in, they want to draw blood to check. Remember, what happens with chest pain is deprivation of oxygen, right? And it is the muscles of the heart that's affected. So any areas of the muscle, the myocardium, that is deprived of oxygenation will show ischemia or infarction. All right? So they draw when the muscle is damaged. The muscle will release enzymes, and the enzymes will show, the elevated enzymes will determine, will be an indication that there has been the muscle damage. All right? So the cardiac biomarkers, creatine kinase, troponin, and myoglobin. These are the three biomarkers. They're looking at these levels. Once there's damage to the heart muscle, the myocardium, they start going up. They see an elevation. Cardiac biomarkers, they draw 3 times. All right? So they don't use just one time to confirm the problem. They have to draw series of it. Remember I said, once the muscle is damaged, it starts releasing these enzymes, and their level starts rising in the blood. So they take it now, they want to do every 8 hours, 3 times, times 3. All right, so they do these cardiac biomarkers. They say cardiac enzymes. They're also called cardiac enzymes, right? They said they want cardiac enzymes drawn. Enzymes. Q every 8 hours times 3. 3 times. So they come now at 6 o'clock, they draw it at 6. The next time is due 8 hours later, 2 p.m. The next time is another 8 hours, what? 10 p.m.? 6, 2, and 10. Every 8 hours. Now, they will look at the 3 levels. They look at the troponin, those 3. Troponin, the CK, creatine kinase, and the what? The myoglobin, right? And they look at their levels. They're looking at their levels. So the first one they drew at 6. They look at the level, right? Then they check the one at 2. Was it continuing to go up? At 2, at 10 p.m., was it going up more? That's what they do. 72 hours later, they start falling down. They start dropping. Those levels that are elevated will now start becoming, decrease. So they use that also to determine the course of action. Because sometimes, remember we're talking about women and not having the typical symptoms, and they take long to come. So if that started this morning, let's say last night, they came back from work, they're so tired, and they felt like a little bit of chest pain, a little bit of indigestion. These are some of the signs women experience, some indigestion. And then they said, they go to bed. So in the morning, they wake up again with the same thing. This is like already over 12 hours they've been experiencing this. So it will be going up. You see that? And by the time they come there, they want to know. So if they say that, okay, for the past 2 days, they've been feeling this on and off, problem, then they won't even do anything right away, emergency, because they have been able to maintain this for over 24 hours. And then they, decide what they want to do. But these are the things they look at. Magnesium level also, they want to look at magnesium level, right? Magnesium helps with cardiovascular functioning. If it's too low, it can affect heart functioning, right? Same thing, I do talk to you about the communication, about orders. When you get lab results, you need to give it to the right person. You need to read back and say, I want to read back to you, right? We talked about that. Invasive studies, angiography. We didn't talk about angiography, right? With respiratory. Same thing. Now, remember I said there's sequences. They do all those tests, echo, then stress tests, then angiography. Because now they want to go inside the catheter, they want to go inside with the catheter to see the vessels, how they are, right? To now see how narrow they are, right? So they do angiography. They can just do angiography, and remember, they go through the femoral artery. Remember what I told you about what to do when they do post angiography? You got to take care of the patient. They have to lie down for at least 4 to 6 hours straight, not getting up, with the leg straight. They can't bend that leg. You don't want any bleeding, right? Complications, bleeding, hematoma formation, right? They can have arrhythmias and stuff like that.
Hold the site for 5 minutes or 20 minutes?
Oh, they put big pressure there. Sandbag. It's not even that. No, the 5 minutes is ABGs. Right? Just holding it like that for 5 minutes, you do ABGs through the artery, it's deep, it's painful. 5 minutes you hold. Like arterial, femoral line, forget it. They use heavy pressure, like sandbag, or they have a device that they actually tighten to make sure it doesn't bleed. All right? Usually when they do this too, they give them a little bit of blood thinner. They give them a little bit of heparin, to prevent aggregation, as they're doing the procedure. So they are also at an increased risk. And also because they have chest pain, they are on maybe heparin, on aspirin, so they already have problems, for bleeding or prone to bleeding. All right? So they have to put the pressure there. Same thing, angiography catheterization, same process. The only difference is that during catheterization, they now try to fix it. So if they went in and they saw that there's so much narrowing, now they do an intervention during catheterization. The intervention will be, see that the plaques that we saw, you can put a balloon, open up a balloon to force it, push it to the wall more, right? So it's called angiography. Angiography, right? No, wait. Huh? What is it?
Balloon pump that they...
Well, no, it's not balloon angiography. That's what it is. Balloon angiography. But it is an intervention. Okay, it's an intervention. Balloon angiography. They put balloon to hold it in place, to open it up a little bit more. Now, sometimes the narrowing might be so much that the balloon will really not do it. Then they will now put a stent. You put a stent. Okay, stent in place, a little metal mesh, and leave the stent there. It forces it to kind of stay open. And this person that has a stent must be on blood thinners. Plavix is the one that they give them to prevent aggregation around the mesh. Because blood likes to go around anything that is in the place and try to aggregate, and the platelets like to go, clump around it. So they give them, they have to remain on Plavix, for a long time, over 6 months, a year or more, and it helps to keep the blood flowing and prevent clotting around the stent, right? So same process of care for the angiography patient you do for catheterization patients. Remember, they have to get fluid to flush it out of their system after the procedure. They have hemodynamic monitoring where they actually put an A line into the heart to monitor the pressures within those chambers of the heart. So the pressure through which the blood is flowing through the vessels. So that's what hemodynamic monitoring is. Inside a line, an arterial line, into the heart, into the large blood vessels to monitor pressures. Okay? They have electrophysiologic studies for those people who are having all those abnormal dysrhythmias, and they send them to a lab, electrophysiologic lab, and they monitor, and they can correct some of those abnormal electrical activities. They can correct it there by giving them medication and monitoring them, intravenously. And, so these are the invasive studies, right? So here's cardiac cath, and they're in there, they're monitoring on the monitor. Therapeutic interventions, we need to incorporate these things to be better, right? For cardiovascular disorders. Walking program, right? So people who can't run, they can at least incorporate walking, little walks, right? And they encourage us to park our cars far away and walk far, right? Do we do it? I don't like to park far. Cardiac rehab, right? If they've had, open heart surgery, maybe so many vessels during the catheterization was found to be bad. You know how people go and they have double bypass, 2 blood vessels, triple bypass, 3 blood vessels that are narrowed, or quadruple bypass, 4 blood vessels, the coronary vessels, right? So that's what happens. They come back, if they've had open heart surgery, they've had, so they would not have to go through cardiac rehab to recondition themselves, right? And when they have, bypass, they usually get the vessel from their body. Remember, they get it from what is called a saphenous vein on their leg. So they take a portion of the vein from their leg and use it to do the bypass. So when they come back from open heart, they have a suture line here. They also have on their leg where they harvested the vessel. And you have to monitor them. You watch here for signs of infection. You watch the one on their leg to make sure it's healing, right? So therapeutic interventions, cardiac rehab, they learn how to now get back into their usual activities. Because after an open heart surgery, it takes a while, right? They have to go through cardiac rehab. If their habit is smoking, they need to stop, right? They need to cease if they are smoking. Balanced diet, weight loss, right? More balanced diet, better nutrition. And if they were obese, then they need to do some weight loss, right? Oxygenation status, they may need to be dependent on oxygen. They may be short of breath quite a lot, right? So they don't need to overexert themselves, they don't need to do too much extra, right? So they need to understand that, and maybe they may need that additional oxygen if they're so short of breath, all right? And anti-embolism stockings, we don't want blood clots, right? That person who's immobilized and laying down for so long, complete care has a tendency for stasis. And we use anti-embolism devices, right, to prevent blood clot, to improve blood return to the heart, improve perfusion, right? Elastic stockings, right, which is really hard to put on, right? Anti-intermittent pneumatic compression devices. Those ones, that they have in the hospital, in the nursing home too. And it's for those patients who are immobilized and cannot turn themselves, so they put it on to prevent stasis. Because then something is pumping their feet all the time to prevent aggravation and blood clots, right? Medications for cardiac, a lot of meds.
Can you repeat those?
This one?
The intermittent
Pneumatic compression devices, Venodyne boots, like Venodyne boots,
Oh,
they have
wow,
those
I know
boots, right, that they put on their feet. Some people use the stockings, some places they have the devices, and they are called intermittent compression device. Because intermittently they go on and off. So for the 2 legs, one leg gets inflated now. So when it's inflated, it helps to perfuse the blood, push the blood through, right? And improve blood return. And then that one, once it's inflated and then it deflates, then the other leg, intermittently. So that's why they're called intermittent pneumatic, because it's pressure, compression device. Meds, a lot of meds, cardiac glycosides that help with the contractility. If there's problem, if they have so much narrowing, we need to improve contraction of the muscles. So they can have cardiac glycosides to help with contractility, like the digoxin. Vasodilators, we have narrowing, but the walls of these vessels are smooth muscles. We need them to be able to dilate when we have the hardening. So we give cardiac vasodilators to help dilate it a little bit more, open it a little bit more, right? We have antihypertensive meds. We have pressure built up because of the narrowed blood vessel, because of the hardened blood vessel. So they have high blood pressure. We give antihypertensive meds, right? Vasodilator is like nitroglycerin, nitro. Antihypertensive meds, several hypertensive meds, right? We have different groups of hypertensive meds. Calcium channel blockers, ACE inhibitors, we have so many. Beta blockers, there's a lot. ARBs, right? Antidysphotic agents, right? Propranolol can be an example. Anti-anginal meds, anti-angina. So patients with angina, nitro is a major one. And the vasodilators are anti-angina. So you give like a nitroglycerin to help open up the airway, prevent the angina pain.
So all these medications are for opening up.
Yes, it helps because we're talking about cardiac problems, right? Anticoagulants, we don't want stasis, we don't want platelet aggregation. So heparin, Lovenox, right? You see all those patients who are immobilized, they put them prophylactic anticoagulant like Lovenox. They get that Lovenox shot every day, which is low molecular weight heparin, yes.
Do we need to know the names
Of the medications, yes. There's a page in your book with all the meds. That's it. You gotta know all the cardiac meds, you gotta know it. You can't avoid it from now till you graduate, you gotta know them. And to know them for clinical too, because when you have to give those meds, you gotta be able to explain what these meds are. What are they doing? You gotta know meds, side effect of meds. What's your responsibility? Do you need to do blood pressure before you give it?
even for exams?
For exams, for clinical, for NCLEX, for graduation, you gotta know it. You can't avoid this one. It's a whole bunch of meds. It's a whole lot of meds. The best way to know it is to learn them by class. And there are certain ways to remember them. If we have the beta blockers, they are the LOLs. Those that have LOL at the end. They have the ACE inhibitors, they have the PRAILs at the end. Just simple, some of those ways to know. But you gotta figure out a way to remember them. Alright? They have thrombolytics. Thrombolytics are the ones that dissolve clots. So when they have clots, remember they are at risk for blood clot development. Once there's a blood clot can dislodge and travel as the blood is perfusing, and it will lodge itself somewhere, a lot of times in the pulmonary vessel, where they cause pulmonary embolism. So anytime the blood clots, right, dislodges, it will cause problems, big time, and they can die from it. So thrombolytics will be the one to dissolve that clot. But there's a window, right? The only time you can use the thrombolytics is within a certain window, all right? And there's a window. What's the window?
3 hours.
About 4 hours.
TPA.
TPA is an example. TPA is an example of thrombolytics. Tissue plasminogen activator.
3
TPA.
hours.
3 hours. 3 to 4 hours. Yeah, make sure whatever is in your book. Yeah. All right. So if the person is able to get to emergency room, hospital within the 3 hours, they can get the blood, the thrombolytic TPA. If that has been going on for like 6 hours, they don't give it anymore. Now they, because they've maintained it and they're fine. They didn't die because that can kill somebody. That is serious because it's the clot lodges in the blood vessel and occludes the blood vessel and prevents blood from moving through. But it may just occlude a little part and still allow blood to flow. So that's why if it doesn't have a detrimental effect after 6 hours, then they can be maintained on just blood thinners and not the one to dissolve the blood. So they have to be within that window. And that's the only time they can receive thrombolytic. TPA is an example. All right, tissue plasminogen activator. And they have other ones that are, So you have to know that TPA thrombolytics are different from anticoagulants. Heparin does not dissolve clot. Coumadin does not dissolve clot. They are the anticoagulants. Coumadin, heparin, right? The low molecular weight heparin, which is the Lovenox. Those are some of the anticoagulants. They don't dissolve clot, but they prevent more clot from forming. They prevent aggregation, stasis, all right? All right, lifestyle and cardiac care. So what are the risk factors? You know, they need to review those factors that put them at risk, like if they're smokers, right? If they have genetic predisposition, if they are obese, if they have poor nutritional habits, if it is sedentary lifestyle, they're not active, right? Some of those risk factors need to be reviewed to prevent or decrease the cardiovascular effect. Then support groups. If they've had open heart surgery, they will need support groups. People, they need to, meet with people who are going through the same thing that can help them. Sexual activity, when can they resume sexual activity? If they've had like triple bypass, quadruple bypass, stuff like that, right? So it's gradual. They go through cardiac rehab and they go through all these different things, all right? If they're gonna have cardiac surgery, there's a prep for the surgery, cardiopulmonary bypass, that's what it's gonna be done. And they have multiple vessels. It's a big time thing, You don't need to know about the details at this stage.
So you need to know about cardiac surgery now?
No. You just, just basic. Whatever is there, that's it. You don't need to know all these big details. Yeah, not now. Right? Take a break. How much break? No, we don't even have 1 hour. Right now it's